Welcome to the second part of the Rheumatic Fever online session. Okay, always remember that you have the sequela or complications of rheumatic fever. The most common presentation in patients with carditis is isolated mitral valve disease, which affects nearly 60% of patients with carditis. Aortic valve involvement alone occurs in 10% of patients with carditis, and mitral and aortic valve involvement accounts for 30% of cases. Damage to the heart valves. Leaflets of the valve tend to thicken, limiting the ability to open, which causes mitral valve stenosis. Scarring of the mitral valve leaflets leading to regurgitation, leading to both mitral valve stenosis and mitral valve regurgitation. The peripheral signs of aortic regurgitation are most commonly due to the high flow state, large stroke volume, and wide pulse pressure seen on aortic regurgitation. Now, this slide shows you the peripheral signs of AR. Another peripheral signs of AR. And also other peripheral signs of AR. Okay, now remember that there is what we call the secondary prophylaxis. Okay, so how do we categorize and the duration of treatment? For rheumatic fever without carditis, minimum injection or taking of oral penicillin is 5 years or until 21 years, whichever is longer. For patients with rheumatic fever with carditis but no residual heart disease, no valvular disease, minimum of 10 years or well into adulthood, whichever is longer. And for those with RF with carditis and residual heart diseases such as persistent valvular disease, at least 10 years since the last episode and at least until 40 years, sometimes lifelong prophylaxis. Now, how do we treat? First, you have to give anti-inflammatory drug. For patients who manifest only with arthritis, the drug of choice is acetylsalicylic acid or the ASA at 75 to 100 milligrams per kilogram per day for 1 to 2 weeks and 65 milligrams per kilogram per day for 6 weeks, then taper. Then for those with carditis without cardiomegaly, ASA times 2 weeks, then 65 mg per kilogram for 6 to 8 weeks. Then cardiomegaly or congestive heart failure, the choice is prednisolone, 2 milligrams per kilogram for 2 to 4 weeks, then add ASA on the final week of prednisolone and continue for 6 to 12 weeks. Indications for acute inflammatory treatment includes joint symptoms, new organic murmurs, changing heart size, congestive heart failure, and your subcutaneous nodules. A sleeping heart rate greater than 100 beats per minute, erythema marginatum, chorea, a positive test for C-reactive protein, and unexplained fever with a rectal temperature of 100.4 degrees Fahrenheit for at least 3 consecutive days. Now, there is a separate management for chorea. You need to advise the patient to have bed rest and avoidance of stress. And for severe symptoms of chorea, you need to give phenobarbital 15 to 30 milligrams every 6 to 8 hours, and also or your Haldol 0.5 milligrams gradually increased to 2 milligrams every 8 hours. For patients with significant carditis, you need to give digoxin or lanoxin, which is an inotrope, at 0.04 mg per kilogram per day in 4 divided doses, then maintain BID. Then you also give diuretic furosemide in combination with potassium or spironolactone to decrease the degree of regurgitation. Now, always remember that the most commonly valve involved in rheumatic heart disease is the mitral valve, and the most common valvular pathology is mitral regurgitation alone, particularly in children or in combination with MR and AR. Now, for moderate AR and MR, you need to give lanoxin, diuretic, and also your ACE inhibitor, your captopril. Now, always remember that you need to advise bed rest in any patient diagnosed to have rheumatic fever. So, bed rest, okay, it depends whether you have arthritis alone, minimal carditis, moderate carditis, or severe carditis. Then also, always remember that the bed rest can continue as outdoor, then activity, school for 2 weeks, then full activity. Now, okay, patients with significant valvular pathology such as your MR, MS, and AR should have a bacterial prophylaxis before any procedure. So, the standard general prophylaxis is amoxicillin 50 mg per kilogram per ORM 1 hour before the procedure. For those unable to take oral medications, you may give ampicillin 50 mg per kilogram IM or IV 30 minutes before the procedure. And for those allergic to penicillin, you can give clindamycin 20 mg per kilogram per ORM 1 hour before the procedure. Okay, so for any patients with rheumatic fever, there is still hope for rheumatic fever patients to have normal hearts if one is aggressive with secondary prophylaxis regimen. Thank you and God bless.